atrial rate, ventricular rate may be slower. Rhythm, irregular. P wave, normal, evenly spaced. PR interval, fixed, consistently normal or longer than normal. QRS may be normal or wide, missing after some P waves. T wave, normal after QRS complexes. Some impulses are blocked in the AV node, causing a dropped QRS. The significance is that it can follow myocardial infarction or stem from conduction abnormalities. Frequent blocks reduce cardiac output, causing hypotension and bradycardia. The best treatment option for frequent blocks is usually pacemaker insertion. Third-degree atrioventricular block. Rate. The atrial rate exceeds the ventricular rate. The ventricular rate is below 45 beats per minute. Rhythm, irregular. P wave, normal. PR interval, P waves and QRS unrelated. QRS, typically widened. T wave, normal when following a QRS. Passage of impulses through the AV node is completely blocked, so that the atria beat at the usual SA rate and the ventricles beat independently at an intrinsic rate of 30 to 45 beats per minute. The significance is decreased cardiac output, hypotension, or bradycardia. Treatment is atropine, followed by pacemaker insertion. To review, all symptomatic bradycardias are treated the same, either with atropine or pacemaker insertion. Ventricular dysrhythmias include premature ventricular contractions, ventricular tachycardia, and ventricular fibrillation. Premature ventricular contractions, PVCs. Rate, normal. Rhythm, irregular. P wave, normal except absent before a PVC. PR interval, normal except absent with a PVC. QRS, bizarre with a PVC, otherwise normal. T wave, opposite of PVC deflection, normal with other QRS complexes. An impulse is originating in the ventricle that causes a contraction before an impulse is received through the AV node. The significance is that it can be caused by myocardial ischemia, digitalis toxicity, electrolyte imbalances, stress, and sympathomimetic agents like dopamine. Frequent PVCs decrease cardiac output. Occasional PVCs require no treatment. Frequent or symptomatic PVCs are treated with antidysrhythmic drugs like amiodarone, lidocaine, and procainamide. Ventricular tachycardia. Rate, ventricular rate 100 to 250 beats per minute. Rhythm, ventricular rhythm usually regular. P wave, cannot assess. PR interval, none. QRS, wide and bizarre. T wave, deflected in the direction opposite that of the QRS. This pattern is ineffective for maintaining cardiac output. This is a potentially life-threatening dysrhythmia. The significance is that possible causes include cardiac disease, hypokalemia, and digitalis toxicity. Cardiac output drops precipitously and it may progress to ventricular fibrillation. The client may report palpitations and will soon lose consciousness. The treatment is defibrillation. Advanced cardiac life support is required if the client has no pulse. If the client has a pulse and a blood pressure, the dysrhythmia can be treated with synchronized cardioversion and antidysrhythmics. As for PVCs, ventricular fibrillation. Rate, it cannot be counted. Rhythm, a disorganized pattern. P wave, cannot assess. PR interval, cannot assess. QRS, cannot assess. T wave, cannot assess. The pattern is ineffective for maintaining cardiac output. The significance is that it might stem from cardiac disease, electrolyte and acid-base imbalances, hypothermia, or electrical shock. The client will quickly lose consciousness, and pulse and respirations will cease. The client's survival depends on successful CPR, advanced cardiac life support, and defibrillation.